Good afternoon and welcome to today's APSASode, sponsored by the APSA Education Committee on the topic, Addressing Today's Educational Challenges Using Technology. I'm Eunice Huang from Monroe Carroll Jr. Children's Hospital at Vanderbilt, and I'm accompanied by my co-moderator, Mary Edwards from Albany Medical Center. Today's APSASode will cover 3 different topics, covering how education is interfacing with technology. Each topic will be led by an abstract presentation, followed by a panel discussion on that topic. The topics we will be covering are burn care and the use of telehealth, virtual delivery of surgical education, and the use of simulation as a tool in teaching technical skills. At the end of our presentation, we will have a live question and answer session during the live broadcast on the APSASode. So I hope that you will stay and participate in that component of the program as well. So without further ado, let me turn the podium over to Mary to start our session.
Thanks, Eunice. We're going to begin our session with the presentation of a thought-provoking paper on the topic of the current state of training in pediatric surgery for the effective delivery of burn care. This abstract was selected by the program committee and will be presented by Joseph Esperaz, who is the Pediatric Surgery Research Fellow at the Children's Hospital of Alabama.
Good morning, and thank you for allowing us to present our research. We have nothing to disclose. Burn injuries remain as one of the leading causes of injury and subsequent death in children. Injuries vary from accidental scald burns to the unfortunate cases of child abuse. Each day, hundreds of pediatric patients are evaluated in the emergency department for new burns. Regardless of the mechanism, burn management is a multidisciplinary effort involving critical care physicians, surgeons, and physical and occupational therapists, to name a few. These cares vary greatly, with some patients requiring simple outpatient dressing changes to others requiring extensive surgical debridement and grafting. Unfortunately, burn training has not been standardized during surgery training. Some graduates end up relying on formal burn fellowships, while others may receive some burn training during additional subspecialty fellowships like pediatric surgery or plastic surgery. With such a variation in education, prior studies have voiced concerns about minimal critical care and burn exposure during residency. As a result, we sought to evaluate the exposure to burn management in pediatric surgery training programs. A unique electronic survey was developed and sent to all program directors at ACGME accredited pediatric surgery programs during the 2020 academic year. Programs were excluded if they declined to participate or failed to complete the survey. In addition, we evaluated the ACGME Pediatric Surgery Fellow case logs for a 15-year period. Specifically, we identified and reviewed cases logged as burn debridement or grafting. Descriptive statistical analysis was performed. A total of 36 programs responded to our survey, resulting in a 64% response rate. 56% of responding programs participated in both burn management in an inpatient and outpatient setting. Unfortunately, 20% of programs had no burn management at all. In addition, the programs that do participate in burn management, only half reported active pediatric surgery fellow involvement with burn cares. From a logistics standpoint, we also wanted to evaluate the burn workforce. We identified the majority of programs do not have dedicated burn surgeons, and over 60% of programs rely on general pediatric surgeons for burn cares. With such a reliance on pediatric general surgeons for burn management, we opted to review fellow case logs to evaluate the exposure trainees received during fellowship. Over a 15-year period, we identified an average of 10 logged cases per year. Unfortunately, this average is artificially inflated by a small number of programs that log more than 100 cases a year. In reality, we identified a median case of 0.58 cases per year, with more than half of the years reviewed having a median case of 0 cases logged. To put this into perspective, this means over half of the trainees have no operative exposure to burns during their training. In conclusion, we want to emphasize that the ACGME does not require formal burn rotations during general surgery residency or subspecialty fellowship. Without a requirement, we have identified inconsistency with burn training, with many pediatric surgery trainees having no formal training during their fellowship. In addition, we identified a heavy reliance of pediatric burn management on pediatric general surgeons, potentially ones that haven't had much training. Inconsistent training has led to many unnecessary transfers and an over-reliance on burn centers for patients that simply need outpatient burn cares. We believe increasing exposure to pediatric burn management during general surgery residency and pediatric surgery fellowship is needed. This will in turn lead to improved cares for this patient population. Thank you.
All right, well, thank you very much for giving me this opportunity. Joseph, I really enjoyed listening to your presentation. At Connecticut Children's, we do have resources located in Bridgeport and Shriners, but both of those are not really optimal for some of our patients and local families. A recent article out of the Journal of Pediatric Surgery in 2020 also highlighted this interhospital variation in inpatient versus outpatient pediatric burn treatment, and actually also highlighted the cost, the ineffective cost of this. So that's why I think this abstract was incredibly timely. I do have 3 questions for you, Joseph. My first question was, how do you think burn centers would view your data? I wonder if they have been feeling a strain due to the over-reliance on burn centers for minor burns.
Sure. I also think that burn centers would be surprised with how many surgeons do not have formal training during general surgery residency or fellowship training. And in addition, I think this would give burn centers a better understanding that transferring physicians are uncomfortable managing burns and potentially overestimating and incorrectly resuscitating those patients.
Absolutely. If the centers have no burn surgeon on staff, you have pointed out that 64% use a pediatric surgeon, yet fellow logs have 0.58 cases per year. Where do you think the pediatric surgeons are getting their training?
So I think that the number of 0.58 cases per year is misleading actually because of the limitation from the ACGME case log system. The system within itself is an aggregate of average of all pediatric surgery fellows, with some logging way more than 60 cases, even though the majority are logging that 0 number. So we believe that pediatric surgeons that are participating in burn cares either went to a program that has a larger burn center associated with it and fellow involvement, or they just feel comfortable managing those burns because they had a burn rotation during residency. And then I think pediatric surgeons without burn exposure can actually just learn on the job as well, especially if they're at an institution where a burn care is being performed.
And I think that's what happens with a lot of the pediatric surgeons, but I also think that's why the article that I referenced was written, is because there is so much interhospital variability that maybe standardizing this would be extraordinarily helpful. My last question is, according to the 2020 ACGME core requirements in surgery, 4C8B states that a formal rotation in burn care is not required, yet knowledge of burn physiology, clinical experience with initial burn management is required, and that's a core requirement. And curious to understand how this knowledge is to be obtained. And then the pediatric surgery ACGME 2020 core privileges in 4B1C indicate that fellows must demonstrate competence in their knowledge of basic principles and management of burns, another core requirement. So just wondering how the teaching is supposed to happen if they're not getting this exposure.
Sure, and I think we're also perplexed about how the formal rotation is not required, but clinical experience is required. So I think when I finished residency and spoke to other graduates and some of the fellows, I was shocked to actually hear that none of them or some of them didn't have a formal burn experience. I think that clinical experience is gained mainly during the trauma ICU rotation, where burn patients are initially brought to a level 1 or level 2 trauma center, that burn center. So I think this is where they, in similar fashion, I think from the pediatric surgery fellows, I mean, to demonstrate competency in the management of burns can be as simple as answering questions correctly on the P-site or mock oral boards, and then understanding just the general principles of skin grafting. So unfortunately, though, I do think there are a lot more nuances to burn resuscitation and burn cares that are harder to teach in that non-clinical setting.
Right. Thank you. Thank you very much. I really enjoyed your abstract.
Thank you for these questions.
So for the next portion of this, the panel discussion, I'm going to bring in Dr. Sean Larson, who's the medical director of the burn and trauma unit in Gainesville, Florida, at an ABA accredited adult burn center, and who is also a pediatric surgeon. Sean, I just would like to start by hearing your thoughts on the abstract that Dr. Esperaz shared with us.
Well, for full disclosure, Dr. Byerly actually was a key component of our burn unit here at UF many years ago. I thought the abstract by Dr. Esperaz was very interesting, and I think it really highlights some important factors for learning to care for injured and burned children. When you have, I think it was 0.58 median cases per year per trainee, I just don't think that that's enough exposure. And, it's generated a lot of thoughts, but I'm glad that they did the work, and I thought it was well done.
So this brings up another point that I think is worth delving into a little bit, and that's the provision of telehealth to assist in burn care, because burns are so common in pediatrics, as you know, and burn centers they're a limited resource. So if it's okay, I'd like to go through just a very simple case, and I would kind of like you to maybe function as a telehealth provider and helping me take care of this child that walked through my front door, because I don't have a burn center locally here. So if that's okay with you, we will go ahead and get started.
Happy to help.
Okay, so you are going to be my consultant. So this patient that I would like your assistance with is a 5-month-old former term infant who was brought into an emergency room after being found on the floor prone, wedged against an electric baseboard heater for an unknown period of time. He was alert and stable. Obviously, this prompted a full child abuse evaluation, which we did and was negative. And I assessed his burns as being around 3% total body surface area. And this is what they looked like. So my first question to you is, in your opinion, is this a patient that should be immediately transferred to a burn center?
So it's always a very interesting question. By the ABA guidelines at 3%, you could argue that they do not need to be. I think one of the other ABA criteria is what is the capacity of your center. When I look at that, I don't necessarily think that has to be taken care of in a burn center, as long as the person, such as yourself, that's taking care of the patient is competent to manage a burn wound.
And how would you suggest managing this wound? How would you do it at your center?
So we would obviously do exactly what you did with the abuse workup. Just make sure that's negative, cross all the check all the boxes. The burn wound on the screen left on the face, that the face will heal very nicely. We rarely have to do anything for those types of wounds. I would even suggest a silver impregnated topical dressing. I'm a big fan of these sort of face masks. Cut that to the size, put it on. You don't have to do anything for about a week. It'll heal. That doesn't bother me. The picture on the right, which is much more, or at least on the right that I'm looking at, the arm, it does concern me, especially in that central portion. I think that's a deeper wound. We are pretty conservative with grafting kids, especially a 5-month-old. So, initially I would recommend some sort of collagenase type of topical ointment for 2 or 3 days, kind of watch the evolution, make sure the child's got pain control, make sure the child's got nutritional support. And then after a couple of days, if you're getting good results with the collagenase, continue to move forward with that. I do think it would benefit from a little tidying up in the operating room, but I think you could even still put a skin substitute on and allow a lot of that to heal without having to do a graft, or at least only having to graft maybe a small percentage of that.
Well, I wish I had had you available to me a few months ago. So what ended up happening was we did admit him. We washed out his wounds gently under some sedation, and we just basically put non-adherent dressings and ointments on. We recommended referral to a burn center, but the mother declined. he did go home and came back a day later, and his burn was starting to separate. So we just went with some silver impregnated cellulose dressings, and just saw him in clinic every 2 to 3 days. And he seemed to do okay with that. The first few dressing changes were a little rough and painful, but he ended up doing okay. And then came back, and this is about a week now, 10 days post burn, and his burn had separated, and that's what it looked like. And I looked at that and thought it probably needed a graft. What would you say in that circumstance?
I would back you up on that, but I also, again, given the child's age, given mom's reluctance, you know, I would again go very conservative, and I would even say that instead of putting on a graft right away, is to clean that wound bed just a smidge. It looks like it's got nice, healthy granulation tissue, and you could even put on a skin substitute and allow, again, the edges of that burn wound to heal. You know, you may end up with that upper part on the upper arm there that may heal. The only part that gets me a little nervous is right around that elbow joint, but it is pretty thin across that elbow joint area. So, you know, the nice thing about a skin substitute, or again, and I don't endorse any particular product, it just minimizes the dressing changes. And so that can make it easier on the child, which is obviously most important, but it also helps mom take good care of that wound.
And if we didn't have a skin substitute available to us, what would you recommend?
You know, with that granulation tissue, I would, you know, there's lots of different things I would think of. One of those, you could potentially, well, you could do some Mepilex, or, you know, again, a silver impregnated. I'm not endorsing any product. You could put on a silver impregnated foam type dressing, or you could continue to treat that with Barcenes and or an antibiotic ointment, and just do daily dressing changes. But it's challenging, and obviously in the situation that you're in, you got to kind of do the best that you can with what you got.
Well, I saw this, and I pretty much, again, I wished you were available to me then. I said, well, he needs to be grafted, and so book him for a graft in about a week. But I went on vacation for that week, and my PA kept taking care of him. And a week later, that's what it looked like on the left. And then at the end of the week, that's what it looked like on the right.
Yeah,
And I just
that's nice epithelialization there.
I couldn't bring myself to graft it.
Oh.
So we kept doing what we kept doing, and that's what it looked like a week later. And it ultimately completely healed. He does have a pretty significant scar. He's 9 months post-injury now, but he doesn't seem to have a contracture, at least not yet. So how long would you follow him before you would say that he's out of the woods to get a contracture?
So I have some of Dr. Byerly's patients coming back, you know, so some of those kids were 1 or 2 years old when she treated them, Dr. Byerly treated them, and now they're, you know, 17 or 18. So we actually have a program where we see these kids once a year for a scar check. And, you know, yes, it's extra work, but it just kind of keeps the family in the system, and it allows you to kind of just keep following. A burn compression garment would be also a nice touch to help. I think I read in one of the slides that mom was doing some scar massage, which, you know, sounds a little kind of foo-foo, but actually does work. I would at least follow this kid, you know, probably yearly for at least through some of the major growth spurts, because that's when you're going to find when the scar starts to become a problem. But I think you got a nice result, and I think, you know, in some aspects, the fact that the child's 5 months old probably was your biggest, you know, was the biggest help in that kid. So nice outcome.
So one final question for you. So do you do what we just did in your practice? Will you offer telehealth to other facilities calling in, just kind of like what we just did?
Yeah, absolutely. And certainly COVID kind of pushed that forward a lot more when we were having to do it. It is a challenge for a multitude of reasons. And the multitude of reasons can be anything from, there's a lot of folks out in the United States that don't have very good internet access, let alone access to healthcare, but access to the internet. And we were struggling with some of the patients for them to get onto telehealth, get onto Zoom, and then for us to be able to accurately look at the wound and see, the wounds. But I think that it's really a great way forward. We also had a program where we set it up where we would have outside institutions could email us HIPAA compliant photographs. And then we could review those photographs and say, because you get a lot of people that the kid will get a hand burn, they'll touch a stove and they'll have like a couple of little blisters. And then people want to refer because, the guidelines say if there's a hand burn or something and, they'll come 2 hours and they've got, 3 or 4 little blisters and then you feel bad. So I think that telehealth offers that advantage to be able to look at a wound, kind of give some advice. We've even done some follow-up with a sister institution of ours where the kids will actually go to clinic there. We'll get them on to telehealth, look at it, and then we can also coach up, the physician assistant or the nurse practitioner to do the dressings. And I'll tell you, hand dressings are the hardest. I can't do them. But my nurse practitioner is like super good at it and she can show you on Zoom how to do that. And she's even done it to some parents. You got to be a little careful with the medical legal aspect, which is above my pay grade. But ultimately, I just want to take care of the burn patient. So.
And do you get reimbursed for that when you do that?
We do right now. It's still in the state that I'm in. I hope that it stays because I think that it only adds to what we as pediatric surgeons can do for our patients. And I think it's a great opportunity for us to either consult as colleagues or for us to even get the child on there and have a look at it and take care of it.
All right, well, thanks so much. I really appreciate you discussing this case with me and
great case and great outcome.
Sounds like you're doing great things for the kids in Florida.
Yeah.
So you're providing a great resource for them down there.
Welcome to the second segment of our Education APSASode. The theme of this second segment is on the virtual delivery of educational content. To start our segment, Dr. Robert Baird, Associate Professor of Surgery at the University of British Columbia, will present his abstract entitled Virtual Curriculum Delivery in the COVID-19 Era, the Pediatric Surgery Bootcamp V2. This abstract will be discussed by Dr. Justin Wagner, Assistant Professor of Surgery at the University of California, Los Angeles.
On behalf of all co-authors, thank you to the APSA Education Committee for the opportunity to present. Most authors of this work are members of the Association of Pediatric Surgery Training Program Directors. Todd Ponsky is Chief Medical Officer of GlobalCast. Surgical boot camps are effective educational experiences to promote technical skills and fill knowledge gaps. The first pediatric surgery boot camp was held in Canada in July 2017 with 10 learners in attendance. Since then, it has grown to involve 2 concurrent sites, blending lectures, simulation, and animal labs to address core content, but also the hidden curricula of pediatric culture. The COVID pandemic required a rapid pivot to an online platform. The 2020 camp adapted its structure from prior camps, with input sought from past directors as well as members of the newly inaugurated APS-TPD Bootcamp Committee. Content was condensed into a one-day virtual meeting, with faculty pre-recording their lectures and attending the day for live discussion. Procedural videos were reviewed, a family testimonial was provided, and social component bookended the day. We reviewed the efficacy of the bootcamp through the lens of its financials, learner engagement, knowledge delivery or impact, and stakeholder satisfaction, both the learners and the program directors. 31 programs registered, including all Canadian and just under half of US programs. 42 learners attended, 33 of whom were first-year fellows, representing a 20% uptick from the previous year. The camp cost $15,500 US to deliver, which was covered via association contributions, an industry sponsor, and a registration fee per institution, This was almost half the cost of the 2019 camp, although those were held at 2 sites and over 2 days. The cost per learner was reduced by 2/3. Over the course of the day, over 50 polling questions were distributed, and 300 unique chat entries were noted. 1/3 of these were deemed to be directly related to educational content. A brisk social media presence was also observed. While 2/3 of learners completed the pretest, only 17% completed the post 8 weeks later despite multiple reminders, meaning a paired analysis could not be performed. We did note that the test did discriminate experts from novices, establishing construct validity, and that the aggregate post-test performance was significantly superior to the pretest. Learners generally agreed that the camp assisted with transitioning to fellowship and provided a sense of camaraderie. They appreciated the lack of travel, but noted screen fatigue and expressed that they would have preferred an in-person experience. 22 program directors responded to the survey, including 7 whose institution did not participate in the camp. An important minority of respondents disagreed that the camp was worth the cost, with 4 PDs suggesting it should be eliminated altogether. Respondents were split around whether the in-person or virtual camp was preferable, with several PDs expressing concern about the financial sustainability of the camp into the future. The virtual pediatric surgery camp reduced expenses and travel, increased attendance, achieved knowledge transmission, and has allowed for the archiving of content. However, learners and PDs, no doubt like many of you watching, favored an in-person experience. We trust these data will inform future iterations of the camp, particularly with travel restrictions ease, and course directors will have a choice of offering an in-person, a virtual, or hybrid option. Thank you, and looking forward to the discussion.
It's really an honor to be discussing this presentation from the Who's Who list in pediatric surgical education. This was a great example of the so-called pivot that so many in curriculum had to take during the pandemic. Dr. Baird, it seems like fellows preferred the in-person venue, program directors preferred it virtual. Is there any more to this interpretation than fellows want a break and PDs want a fellow?
Thanks, Justin. That's an insightful question. I'd say it's a little more nuanced than that. I think both fellows and program directors saw the advantages and drawbacks of the virtual format and perhaps interpreted that a bit differently. My take on things is that the virtual format really has helped address some of the diversity, equity, and inclusivity issues that plagued the boot camps in the past. It definitely allowed for more people to attend. It definitely decreased the barriers to attend. From the perspective of a program director, it did allow fellows to more easily pop back out and jump back into their duties. I guess the question is, each of those groups, that is the fellows and the program directors, I think weighed the advantages and drawbacks differently. Certainly all of us want to get back to an in-person format, and that's true whether or not it's a boot camp or maybe interviews, but certainly our meetings. That said, no one can deny that Zoom and all these virtual formats have increased attendance at all of these things, and that's a good thing. So I guess it's a question of which silver lining you want to prioritize more. That said, a lot of what we experienced with the boot camp this go around has informed how we intend to offer boot camps in the future. Right now, that's under the direction of Drs. Poolagandla and Fairbanks, but as a committee member, it's been my privilege to sort of learn from what we accomplished last year, and it is helping us inform what we're going to be offering in the years to come.
And that's a great segue to the next question I have, which is, moving forward, how will you and the rest of the APS-TPD decide what elements are going to be virtual and what will be in person in the boot camp?
Yeah, so we're still working through that process, and stay tuned. The next iteration of the boot camp is being offered early this August. And what I would say is that it builds on what we have already created. So a lot of the material created in 2020 has been archived and is available to our incoming fellows. And during that session, I think we were still novices when it came to things like breakout sessions, how to maximize engagement. But I would say that we're a lot wiser now, and the current coordinators of the camp are really going to leverage some of those experiences to make sure that engagement really is held from the beginning to the end of the meeting. And there's a lot of other strategies I'm aware of to minimize the old Zoom screen fatigue. But that said, some of the curriculum is similar. I think it's just a question of packaging it in such a way that it is maximally impactful.
That's great. And as you track forward, how will you track the success of the boot camp's educational mission overall? In other words, will you be able to answer the question of whether programs and fellows are getting their money's worth in future iterations?
Yeah, Justin, that's a good question. This scientific work is the third that I'm aware of that has analyzed the pediatric surgical boot camp, the first being more of a needs assessment. So I'd say there's a fairly rigorous scientific foundation that sort of proves the concept of the boot camp. When you ask about money's worth, well, we're decreasing the money input, and the initial cost has come down. I don't know what we're charging in 2021, but it was about 150 per program last year, and I think it's even less this coming year. So I think it's a nominal financial investment really for a program. And I think it's hard to quantify some of the benefits. Yes, there's the knowledge impartment, but I also think more importantly, there's the inculcation to a pediatric culture and a feeling of camaraderie amongst fellows. We all know, those that have been through it, it's a really short 2 years. It might feel like a long 2 years, but boy, it sure feels nice, I would have presumed, to have confrères and consoeurs, that is, brothers and sisters in arms, as you go through that 2-year intense process. So we will continue to monitor it. There's an ongoing committee at the APS-TPD to continue to ensure the boot camp is meeting its objectives. Not sure yet how we'll be scientifically studying it, to make a long story short, though.
Thanks for doing it in the first place. Really fantastic presentation, fantastic program, and wish you all the luck in the future.
Awesome, Justin. Thank you very much.
Thank you, Dr. Baird and Wagner. Continuing on this topic of delivery of educational content in a virtual format. Over the last 2 years, the APSA program committee, led by Dr. Casey Calkins, has performed the tremendous task of bringing the APSA annual meeting to our living rooms by leveraging cutting-edge video conferencing technology. Dr. Dave Powell has also played a significant role in this process, as well as Dr. Todd Ponsky and the GlobalCast MD team. So to talk a little bit about the lessons learned through this experience are Drs. Calkin and Dr. Powell, and with them is Dr. Kathy Van Leeuwen, who is the APSA program chair this coming year and the producer of PSurge TV. So welcome all three of you. Thank you so much for spending time with me and Mary during this APSASode. So I think we're going to have a little bit of a roundtable and talk a little bit about the APSA annual meeting over the course of the last couple of years and all that we have learned. And so we're going to ask you a couple questions, and you guys could just pitch in on what you think about this. Does that sound good?
Fantastic.
Right. Great. So the first question is, how have the goals of the APSA annual conference been better achieved using a virtual platform?
You want me to tackle that, Dave?
Sure, why don't you start?
I think I'll probably speak to the scientific content, which I think traditionally the program committee has largely been instrumental in choosing the scientific content. And what was cool about the virtual platform is it enabled us to enact a invited discussant platform, which I think a lot of people really liked. The downside of that, the flip side, is that people don't get up to the microphone anymore and ask all kinds of questions. But the other positive thing about the virtual platform is it allows people to answer questions online in a chat format. So for those people who are not willing or a little bit timid to get up and speak at the microphone in person meetings, it allows them to ask questions directly to the authors. And we chose to do that in a largely pre-recorded manner, which is a little bit different than the live version, to try to mitigate some of the risk of live streaming, which worked out pretty well, but you lose some of the live interaction between the presenter and the discussant. So I think we accomplished the goals in imparting the information to a wider range of people, which is, I think we've been borne out with both of the virtual meetings, but there are some differences, some good, some bad. And then Dave, I think, can comment about the educational content, which he was largely instrumental in producing.
Yeah, I wanted to first, Casey, kind of reinforce what you said. One of our objectives at APSA is not just this one-way relay of information, projecting what we know onto you. It's an interaction. And having just looked at the data from the last 2 virtual meetings, the amount of people that had a chance to interact with a speaker, whether that was through chat or the Q&A or a Zoom panel discussion, is an order of magnitude larger in the virtual environment than the WWE wrestling match to get to the microphone to be one of the 2 or 3 people that gets a chance to talk to a speaker. That's great. On the downside of that, though, we had a lot of questions that didn't get answered in the virtual format because there were so many formats. So it's kind of a win-loss thing. I think from the educational standpoint, we did a really good job of getting our entire organization, both staff and members, up to speed on how to run a virtual platform. Podcasts and videos and Zooms and all that other stuff. Now we kind of did it kicking and dragging and screaming, but there isn't a single person who in APSA now, I think, who couldn't figure out how to do this. We have just learned so much from the production standpoint, and it's led to new projects like Kathy's Ped Surge TV and a YouTube channel. The other thing we noticed, the other good thing about the objective is, and these are things we already knew, but were reinforced, is pediatric surgeons are really busy people. And so we get somewhere between 3 and 10 times as many viewers in an on-demand environment, a delayed on-demand environment than we do in the live environment. So that means that our message is reaching out to 10 times more people potentially. It also is a little bit less expensive to run a meeting. So although it still costs a lot, we had, price is important, and we have an order of magnitude more people registering and showing up for our meetings because it's on a virtual platform. So I think the interaction was better, but certainly the breadth of how many people we got our message out to was a lot better in the virtual environment.
I would add that you have that same exposure that you have at the meetings for the trainees and for the moderators, and maybe even more so. And so that's one thing that Casey did really well, is making sure that in these 2 virtual meetings that he ran, that there was a wide variety of moderators at different sessions. Those moderators needed to interact with the discussants, which we wouldn't normally do, right, Casey? So you would have, I might moderate a session in a live meeting, but whoever the discussants are really just going to get up to the mic. I don't need to know who they are or have interacted with them before. But in the virtual format, I needed to plan that out. I had to contact those discussants and organize that. And I think that increased interactions and exposure between moderators, trainees, especially with the trainees. Think about all these trainees who got to meet these really cool discussants in their field or in their niche area that they were talking about that they normally wouldn't get exposure to. And that's something that APSA can take a page out of the playbook for AAS and for IPEG, is really getting interactions between younger members and, I wouldn't call them older members, let's say seasoned members. But that's something that we're going to be trying to hold on to, that invited discussant interaction with a trainee.
Really promoted inclusivity by having people be invited discussants as opposed to just having the same 3 people get up to the microphone and ask the same questions. So I think that was a huge plus, in addition to what Kathy and Dave added to my brief comments at the beginning.
So on the other side of that, so Casey already sort of alluded to the whole socialization aspect of meetings. And I think for most of us, and maybe it's not all of us, the whole networking thing over Zoom, it still kind of feels a little bit contrived, and we all kind of struggle with that. But what do you all think the downsides were of doing this on a virtual platform? What were the big drawbacks that you saw?
I think you mentioned the biggest one, and that's the need for human interaction and seeing old friends, and that's always one of the, I think for most people, probably the best part about going to APSA or any other meeting for that matter is seeing friends and having dinner or drinks or just catching up on life and that sort of thing. And so you lose that in a virtual platform to a certain degree. And even though we tried to have like a virtual, rooms in the first one, that nobody really utilized them because it's just not the same. But I think that from an educational standpoint, I think we accomplished all the goals we would at a meeting. It's just it's hard, and it's impossible to recapitulate that in this environment. I think we can try through social events and that sort of thing, but it's just not the same.
Well, I think now Casey's in charge of the new the Council of Chairs.
Council of Chairs,
so the COC, the Council of Chairs, is a group of all the chairs of all the committees and the vice chairs as well. And I think that in a way that will be a little bit of an interaction that'll be happening throughout the year. And then once the actual meeting hits, I think hopefully, Casey, you can lean on this Council of Chairs to really increase the social interactions. But it was made clear in the Council of Chairs meeting if people are craving that interaction. And so the in-person meeting, however much of it is hybrid, depends on how important does the social part become. And so we'll still have the scientific content, the invited content, but this social content, I think, is going to explode next year. And because it's what was missing, is what people want. But Dave, you were saying how we have a lot of data on what was missing, from this year, what people complained about, and I saw some of those comments as well. But what did the people who viewed our meeting say was missing?
So I'm going to bring up an elephant in the room, and I'll bring it up because it's my life. The technology sucks. It just is. Technology lies. For an organization of our size, with our manpower and our resources, that can't generate its own platform from scratch, we rely on third-party vendors and technologists and all those other things. We had almost half of the people who attended both of these meetings have some kind of technical glitch. And on the one hand, technology is technology, but that glitch forms a wall between our learners and our teachers or viewers and whatever you want to say. And that really was disappointing to me from a user perspective, and I know that the group worked so hard to make this come off without a hitch, and we had lots of hitches. And I think that's going to roll forward, Kathy. We'll have to figure out how to get around that obstacle of technology not working out for us as much as we would like.
Yeah, because you still want to invite the international audience that we think we gained, right?
Correct.
So how do we do that? And it has to be some sort of hybrid presentation, because those same people who can't travel all the way to the United States for those 3 days still now they're not going to take it if we take it away from them. Like, we gave it to them for 2 years, now you can't just take it back. So we have to figure that out.
Yeah, so that's a great segue to our next question, which is, so now what, right? So we've done this for 2 years. We've used different platforms. We've changed things up a little bit. So what do you guys envision that 2022 is going to look like? What have we learned, and what are we going to carry forward, and what are we going to bring back from pre 2 years ago? What do you guys think?
Well, I think all of that runs through Dr. Marjorie Arca, who holds the purse string for our organization, because to Dave's earlier point, meetings cost money. And even though the virtual platform compared to the in-person platform is not as much, if you do both, then there are challenges in terms of what we can provide in terms of content. But I think, I don't know, there's going to be a lot of discussion about within the board and the program committee and the PDC, et cetera, about what is right. But to Kathy's point, I think some people are going to want to have this meeting in San Diego be a lot more social, which will be a lot more fun, but you have to find room for all of the educational and scientific content. And so that's where the Ped Surge TV comes in, to be able to offset some of the educational content that people are so thirsty for when they come to the meeting, but perhaps defray that off over the course of the year and have the meeting be some really high quality stuff, maybe some innovative educational things, and then a lot of social things. And then boom, we continue with the entire year with virtual content that can be viewed by members if they sign up for the meeting. That's my own personal thing. I don't know if that's going to come to fruition, but it'll be something probably similar to that.
And each of the committees,
go ahead, Kath.
Well, each of the committees now has this opportunity to have this moment for themselves. That's what we did over the last couple of years, is to have breakouts for each of the committees instead of having the education day that was separate. And so if we continue that, that's still a lot of content, too much for anyone to consume. So we have to figure out a way to record it for people who want to watch it, or come up with really cool, innovative ways to interact during the meeting in those breakouts. And so you got to pull in people like Rod Gerardo and Todd and his entire team. I mean, Todd Ponsky is developing an entire training program for this type of content, and it's brilliant. It's just, it hasn't quite caught on. It's like anything. I don't want to say it's like Apple or Facebook, because that's ridiculous, but it is. Like, once it happens, it's going to explode, and it already has started with his international audience. But when you get on Stay Current, you see what kind of content is there, and we're going to have to start getting these down into little bite-sized pieces for people to watch, even during the meeting. And so we need to brainstorm with ways to do that. So Dave, I don't know if some of that's free. I can get somebody to live tweet the trauma breakout, for example.
Sure.
And if you're live tweeting it, anybody from around the world can be interacting with you on that. And so to me, that's free, but maybe it's not really.
No, Kathy, I think you're right. Even though we may all be vaccinated and there's no longer a COVID-19 requirement for us to meet virtual, in 2022, the world is not going to be the same that it was in 2019. We all are going to have different needs. We've set different expectations. And I think the goal needs to be, whatever this hybrid meeting is that whatever technology we use, we don't use it just to wow. We use it to meet the needs of the users who have changed since they did the last time we did an in-person meeting. And I'm not 100% sure where that's going to go, but it's real. I think it's super exciting that we've got this experience of a virtual platform. We've always had the experience of an in-person platform. And APSA does a really good job of innovating and making things work. So I'm really excited to see how the hybrid meeting goes and how it meets everybody's needs.
Me too.
Well, Kathleen, David, and Casey, thanks so much for spending some time with Eunice and I this evening. And I think just to wrap things up, one thing that we haven't heard from, and that I'm sure the program committee and the education committee want to hear, is the opinion of people that aren't at this roundtable moving forward, figuring out the best way to deliver this content in a way that's meaningful to all of our members. So I know all of us would love to hear from any and all of you regarding how you think this should be done in the future. So thanks so much for tuning in, and please stay tuned for the live discussion. Thank you.
Thanks, everybody.
Thank you.
Stay healthy.
Hello, everyone. Welcome to the third segment of our education APSASode on addressing today's educational challenges using technology. In this segment, we will be talking about teaching technical skills and the use of simulation. To start off our segment, Dr. Nicholas Kurtich, he's a general surgery resident at Rush University. He will be presenting his abstract titled Percutaneous Peritoneal Drain Placement, a pilot study of pediatric surgery simulation-based training for general surgery residents. Thank you, Dr. Kurtich.
Thank you for the opportunity to present our work. I have no disclosures. It has become apparent that attending and residents feel surgery training may be inadequate. This is likely due to policy change to improve patient safety and case efficiency. Evolution of training with an 80-hour work week and increase in subspecialization has also contributed, as well as change in surgeon expectation, especially with increased OR involvement. Therefore, SBT has become a popular platform to teach surgical residents and fill this gap. SBT in pediatric surgery is still in its infancy, but growing fast with around 50 published simulation models. It is an ideal platform too, since case volume and experience may be low, especially for rare pathologies. We previously created a curriculum for multiple pathologies, including neonatal bowel perforation. Our aim in this study was to assess whether SBT for placement of a percutaneous peritoneal drain was feasible and led to skill acquisition, retention, and increased resident confidence. With the initial design of our curriculum, a needs assessment was completed and the need was established. A low-cost inanimate model of necrotizing enterocolitis or spontaneous intestinal perforation was created, as shown here. In this study, we had residents complete a web-based curriculum which consisted of a video of the procedure and a textbook chapter on perforated neck and SIP. They then completed a confidence survey on their ability to perform placement of a percutaneous peritoneal drain. They then completed a standardized case and were assessed on their technical skills and proficiency, and then completed a post-test confidence survey. They were then given a 3-month interval in which they had 24-hour access to the model and had time to master their skills in the lab. Afterwards, they again completed the drain placement and were assessed for proficiency. They also took an additional post-test confidence survey. Wilcox and Sign rank tests were used to evaluate differences in confidence and technical skills, and an exact McNamara test was used to assess changes in proficiency. As demonstrated here, residents' overall confidence and their ability to assess the patient, prepare for the procedure, place the drain, and manage the patient after placement significantly increased after both the initial testing and at 3 months. Similarly, they had increased technical scores in terms of pre-procedure preparation, placement of the drain, and post-procedure management, as well as overall. At 3 months, 8 of the 9 residents were proficient, which was a significant increase. In conclusion, a pediatric surgery SBT curriculum for general surgery residents is feasible, and residents' confidence and proficiency improved. This is an easy, low-cost model, which is good for residency and for low-resource areas. Moreover, in the future and currently, we have expanded this curriculum to 4 other general surgery residents across the city. I would like to thank my entire team for the help putting together this research and this presentation. And you could find my contact information here. Thank you.
That was a great presentation. Dr. Eric Lazar, Professor of Surgery at Thomas Jefferson, will be discussing this abstract and presenting questions to Dr. Kurtish.
Dr. Skurtich, I congratulate you and your team on the important and practical work in simulation-based training. By way of background, I was one of many authors of the landmark New England Journal paper on drain versus laparotomy in 2004, which really started this practice. And I also am the founding director of a simulation lab for general surgery residents. And so I'm excited to learn specifically more about your model. My first question is, how do you enter the abdomen in your model? How does the trainee know they're in? What drains out of that incision? Can you specifically describe the model and the expected technique?
Sure, thank you for the question. So we use a small infant model, which has a silicone-based skin that's about 2 millimeters thick. And the resident then makes approximately a 1 centimeter incision in the right lower quadrant with a scalpel, and that enters with a hemostat. Unfortunately, it's kind of tough to recreate that pop in drainage, but we do have balloons that simulate both the bladder and the liver, which will pop and deflate if the resident enters in an inappropriate space. And the resident then passes a 1/4 inch Penrose drain into the right lower quadrant and across the abdomen to the other side, and then sutures it in place. And if they do enter into the liver or bladder, we let them know after they hear the pop that they would expect to either have blood or fluid drain out at them.
That sort of actually answers my second question, which was, how do you teach the pitfalls of this procedure, such as a big liver with 2 cephalad and incision? Of course, you're going to end up with bleeding or an ineffective drain. So you sort of answered that with the balloons. Do they actually get that feedback that there's fluid coming out, or is it just the pop of the balloon?
It's really just the pop of the balloon, and then the person proctoring the simulation session will let them know to expect the drainage out.
Very good. And then is your model, the education around your model, the didactic portion, who doesn't get a drain? What is the trainee taught about who should just have a laparotomy?
Right. So kind of answering the inverse of that question is we advocate for the drainage if the infant is under 1,200 grams and has pneumoperitoneum, and mainly in the setting of necrotizing enterocolitis or spontaneous intestinal perforation is what we teach. So if they're larger than that, we advocate for a primary laparotomy.
Okay, thank you very much.
Thank you.
Thank you both for this very interesting discussion. For those of you who are active in the simulation education space, you will all be familiar with Dr. Kathy Barcenes and the great work she's done on education of trainees using simulation. She is known, among many other accomplishments, for her design of mixed tissue models with reusable casings to train pediatric surgery fellows to perform complex procedures in a very small space. We have the privilege of having her with us today to have a conversation about what she has learned from her work. And we also have the privilege of Dr. Yan Chi, who is an assistant professor at Case Western University, who will be interviewing her.
We're really excited to have Dr. Kathy Barcenes here to talk about simulation-based education. As Dr. Huang said, she's a true expert in the field, has published numerous studies, and actually runs the minimally invasive surgery course for pediatric surgery fellows. Currently, Dr. Barcenes is the chief of pediatric surgery at the Children's Hospital of San Antonio. And previous to that, she was at Northwestern University, Lurie Children's in Chicago, where she was the director of simulation. Dr. Barcenes, thank you for being here. I just wanted to start off, I figured we'd start at the beginning. Could you tell us a little bit about how you initially became involved in simulation-based education, and what was the first project you worked on?
Thank you so much for inviting me here today. My journey into simulation-based education is really one of serendipity. Shortly after I finished my training in Pittsburgh and I moved to Chicago to begin a minimally invasive surgical program, I was asked to start hosting the second year and first year fellows courses in minimally invasive surgery. After that brief moment of abject panic at not knowing anything about running a course, I immediately dove into it. And in that process, back in 2007, our techniques for training minimally invasive surgery involved live animals. So we had the small, what we would consider an infant pig or porcine model, but recognizing that that infant pig was already 10 kilograms, so well larger than the size that is really necessary. After 2 years of running a live animal model course, I recognized that there's got to be something different. And that's where the journey into 3D printing began. And the 3D printing is to create the structural surround that replicates the space and dimensions, as well as the characteristics of a chest wall for thoracoscopy or the abdominal wall for laparoscopy. But yet we have to engage the learner. And a learner at the level of a fellow, I'm going to argue even at the level of a resident, and certainly at the level of a faculty surgeon, we need to be operating on real tissue, not operating on plastic. And so we created this mixed model where we use second trimester fetal bovine that is surgically modified, and then putting that into that structural surround. So my journey into simulation-based education was first a request, the opportunity, followed by a recognition that there was a clear educational gap in terms of the tools available to teach these skills.
I see. That's incredibly innovative for you to take that, I guess, relatively new technology in 3D printing at that time and apply it. And I can just say, as a recent graduate, as a recent fellow graduate, we're all better for it. So my next question is, you wrote an article last year about how to achieve expert performance through simulation-based education. And in it, you mentioned 5 proven concepts. I was wondering if you could go over them for our listeners and elaborate a little bit on each point.
Correct. There are 5 proven concepts of simulation-based education. It first and foremost begins with deliberate practice. Now, for whatever reason, when we think about learning to play the violin, it makes sense that you're gonna play the violin and constantly challenge yourself. You start with a simple, doing your chords, doing your runs. You then advance and you get more and more difficult and more difficult. And then even once you achieve that expertise, you continue to focus. Now, what makes it deliberate is you are not actually doing piano at the same time. You're not trying to learn how to play the violin better by playing piano, by playing the drums. While those are necessary complementary skills, you're only going to be the expert if you deliberately choose to practice on that particular skill. So deliberate practice means that you make a concerted effort to work within a specific domain to advance those skills.
Great. And then how about the second point where you talk about the distributed practice schedule? So, you know, as trainees and surgeons, we just have significant constraints placed on our time. And I know as a recent trainee, we often had an hour or 2 a week to devote to something like simulation. So what are some strategies that curriculum developers can adopt to maximize the impact of this time?
So distributed practice is well proven in simulation-based education as being the ultimate goal for any curriculum. In a distributed practice, it is the idea that you you will work, you will then reflect, and then you will come back and work again and then you will reflect again. When you have a single concentrated session, we know that 3 months, 6 months, 12 months down from that single concentrated session versus the same number of minutes spent in the single session, but distributed every month or once a week, that the final outcomes will be far stronger in that distributed schedule. Now, how you translate that into a curriculum, it is extremely critical. First of all, the next key core portion of simulation-based education is that the content has to challenge the learner. If you continue to go to violin practice and play 3 blind mice, pretty soon you're going to get pretty bored playing 3 blind mice. You need to feel that each and every single one of those, that you're being challenged to rise higher and higher. A coach does not challenge you to do status quo on the field or anywhere else in life. A coach challenges you to do better. And so a key part of distributed practice is that the content is actually going to challenge that learner. But remember, the challenge is not in and of itself all that is required. You need the coach. You need somebody to deliver that content, that feedback, whether it's immediate feedback or whether it's at the end of a session that you get the feedback. But you absolutely must have that coaching structure in there. And then finally, as you're working towards mastery, there are defined metrics. So if you have an entire operation that you need to learn, you need to do so in a stepwise progression. You master the first portion, then you move on to the next. You master the next, now you move on to the final. So it's a stepwise progression. And that's what mastery is all about, is you don't try to do everything all at once. You focus in on a specific skill until you've achieved the top level that you can perform, and then you move on.
Those are all great points. And one thing when I was reading through this paper and looking through these points, what occurred to me was, I noticed personally in simulation-based education that there is kind of a lack of engagement among residents to participate when it's not mandated. And you talked about content being challenging, having feedback when you do things correctly or incorrectly. Have you given any thought as to adopting some of the strategies that big companies use to drive engagement, such as incentives or gamification of simulation?
Certainly, there are data that show gamification has a certain advantage. So early on in FLS skills, if you gamify it, if you have a leaderboard that you're posting their names and there's a recognition part of it, certainly we see that that can help in those early stages. But the key part of learner engagement is stick with your 5 principles, but you must also have an educator that is equally as engaged in that curriculum. So if the educator the coach can come in and say, this is where it applies. These are your gaps that I know about in the operating room, and that's how this particular skill will allow you to do more in the operating room, whether it's with me or one of my partners. So it's that active engagement, that active sharing, and that shared knowledge of who the learner is, where they currently are, where they need to be, and who they can ultimately be as a surgeon. Without that engagement on the faculty side, it's going to be really hard to expect unilateral engagement.
Right. And then on that vein, what are some other common design pitfalls you see in a lot of simulation criteria? And what are some of the things that simulation designers can do to avoid some of these traps?
The biggest pitfall is actually focusing on the skills. We're surgeons. We focus on the actual technical skill, but we don't focus on how do we achieve this in that greater perspective of the patient, the disease, the process. So we tend to focus on the actual physical, I'm in the lab doing the technical skills. We forget that when you develop a curriculum, first of all, you need to identify what is the global gap? What is the problem globally for all learners? What is the specific gap that you are seeking to address with this simulation? Is there a specific knowledge gap? Then you write your learning objectives. By the end of this simulation, I would like the learners to be able to demonstrate, illustrate, perform, etc. Then you get to the actual simulation. When you forget these first 3 steps, it becomes just a free-for-all. You practice. Well, what's the purpose? I don't know. It's to get better. Well, get better at what? And so if the educator is not grounded by learning objectives and the learner has no idea what the learning objectives are, the likelihood of achieving any meaningful learning is suspect at best. But then even when you go through all of these stages, it is critical that you then go back and as an educator say, what could I do better? When I assess that learner's interaction with me, when I assess that learner's interaction with the curriculum, where is there an opportunity to improve it? Am I actually really meeting those learning objectives with the available technology? I wasn't with a live animal model in a pig that weighs 10 kilos, but I can in a 3D printed model that is relevant to a newborn infant. So you challenge your curriculum, you challenge your tools, and when they're not sufficient, you go back in and you actually make those adjustments. A curriculum is a living document. It is not a static document.
And I wonder if I could just go back to something you said earlier about not focusing too much on the technical aspects of the simulation. Do you think we focus too much on that kind of simulation? Do we do enough cognitive simulation where we simulate scenarios almost like an oral board kind of simulation?
So scenarios are extremely important when you're looking at cognitive skills. But I'm going to challenge every educator out there. Why do we do cognitive simulation here and we do technical here? Where's the blending of that? And where the blending is with an excellent curriculum. So if you take anything home from this, learn how to write a curriculum the right way. So while they're working on suturing, I'm teaching them this is the C, the reverse C, these are your efficiency metrics. I then throw at them end tidal CO2 is 0. What are you going to do? And they keep operating. No, the end tidal CO2 is 0. What are you going to do? Now they have to stop. And so it's getting them past that cognitive load of I'm focusing just on the technical skills and bringing them back into the OR, even though we're not in an operating room, that there's more than just the technical skill. There's an actual child. There's an anesthesiologist. There's someone else in the room. Or it might be something as simple as I put an instrument in through an accessory port and I cut a blood vessel. Now, I hope my trainees don't learn how to deal with catastrophic bleeding in my operating room, because they should learn how to deal with catastrophic bleeding in the simulation lab. And so if I feel like the learner is at the point where maybe their technical skills are there, but do they have the requisite cognitive skills to handle major complications? Well, then I create them. And that's the advantage of simulation, is you can do that. So I challenge people who set up a curriculum to say, how do you incorporate all aspects of the operating room in there? The interaction with the anesthesiologist, the scrub tech. You know, the scrub tech hands them a scissors instead of a Maryland. We all fear this. Those of us who have been there know to look anytime someone hands you a Maryland to make sure it's not the scissors. But when their cognitive load is focused on the actual mechanisms, they're not able to recognize those simple things that maybe otherwise they would. And so it's a process of developing that expansion of cognitive load that is so critical in the operating room.
I see. And then, just finally, what do you see as the future of simulation-based education?
It's interesting as we look to the future, because simulation is absolutely critical. It is how we maintain our skills. This is where we belong to ensure that we absolutely have a continuation of our skills. We have continuating medical education credits, right? We all get our CME, but what about our CME for our technical skills? Is doing hernias sufficient to maintain your competency for a TEF when you haven't done one in 3 years? There are people who will challenge both sides. I will argue that if you want to be absolutely the top level of your competency, both in skills and knowledge, you continue to seek those opportunities to challenge yourself in a simulated environment where it's safe to make mistakes and it's safe to learn without compromising patient care. How do we do that in the real world? I'm not sure. It's expensive. It's difficult to set up. It is a process. And how do you fund it? How do you find the time to do it? These are all very real challenges, and it's really up to the academic societies. Although it's not distributed practice, it is still focused skills practice. And so we turn to our academic societies to say it's not enough just to do cognitive CME. We need hands-on CME. And while it's not the ideal, there are opportunities to maximize that continued technical training, not just cognitive training.
Well, Dr. Barcenes, thank you so much for sharing your insights. That was really informative.
Thank you so much for inviting me, and it's a pleasure to be here.
Well, that was a wonderful discussion. Thank you so much, Dr. Barcenes and Dr. Shi. I hope that you have enjoyed this session of the Education APSASode, and that you have learned something that will both challenge and inform the work that you're doing in education currently. If you're watching this APSASode during the live broadcast time, I just wanted to let you know that after this segment, there will be a live Q&A session that will be about 15 minutes. So I hope that you will join Mary, me, and all of our panelists for this very lively discussion. Thank you. Good evening, everybody. Welcome to the live portion of our APSASode on education and technology. We're just really fortunate to have all of our panelists. It's been great to watch again everybody's presentations about burn and virtual conferencing and virtual education and about simulation education. So this is the time where you get to ask our panelists the questions that you have, the burning questions you're thinking about as you're listening to the pre-recorded presentation. So please text in your questions and we will make sure that we get a chance to talk about them and answer your questions. So just to kind of get us all started, so Nick, let me ask you first. I mean, it was a great abstract, and I just really enjoyed listening to your presentation and thinking in my head about how I could use your little education, your project to be able to actually teach our residents and fellows how to do peritoneal drain placement. So what I'm really curious about is as you go and start designing the material, one of the challenges of designing a really good model is being to find the proper material that really truly simulates the texture and the tension of a human body and human tissue. So how did you go about designing the model that you have?
Thank you for the question. I think the main thing is using something that you can adjust with each model and that's really reusable or easy to make. So we used a silicone-based product. And it's really nice because you can thin it out, you can lay it down in layers, so you can really simulate different material and elasticity. So that helped with the skin portion of it. We're still really actually struggling to simulate that pop feeling. I think that was one of the questions too by Dr. Lazar. So that's something we're still working on. But with the silicone, it's reproducible, it's very cheap, and we can make it in enough volume so that all the residents can get a fresh piece when we're doing it.
Very cool. Thank you. Mary?
So I'll take the next one. And I guess this will be for Catherine and Sean. So I just was curious, what the two of you think about the kind of startling fact that so few pediatric surgeons are comfortable taking care of burns. I mean, the ABA criteria, as you know, are pretty comprehensive. And I sometimes wonder if maybe that is part of the problem, because it seems like because of the criteria being so comprehensive, people have a very low threshold to send to a burn center. And maybe that's why burn centers have the majority of burn experience. I mean, what do you think the solution is? Telehealth, telementoring, or just more education for more providers, or combination?
I'll take the first comments, and just to compliment Sean on his contribution. And Mary, I think that we all learned from your presentation, and I think it was a really important way to describe how infants and children respond to burn injuries, and that we actually have we have more in our wheelhouse to deal with the kids, and they have more in their stem cell youth to contribute to their wound healing. And I think, if you think about what we have learned as adult general surgeons in terms of what burn algorithms are, usually, do all of our moist wound healing. We do our debridement and then moist wound healing. And, by about a week, the partial thickness portions of the burn will heal. And then by about 2 weeks, we know what's going to be declared as full thickness and in need of further treatments, be it skin substitutes or skin grafting. And I thought Sean made some really good points about utilizing skin substitutes in children to get as much bang for your buck out of what their physiology will give you. And I think it's really important to note that all of our institutions are going to have different resources, and that part of the education for our trainees should just be about kind of broad concepts of what's available, what you can use. Not everybody's going to have all the same materials, but there's lots of things that can work in different institutions depending on what you've got. And then just finally, this whole idea of telehealth, the fact is that, in all of our ABA centers, and I am not a fully fellowship trained burn surgeon, but I just got into the business because in my region, we were sending kids and families hours away, like 6 to 8 hours away for burn care. And most of it was being sent back for outpatient management. And so there was just a lot of, there was just a big need for understanding what could be taken care of locally, and the idea of understanding what needs critical care and then what you can deal with and manage. And finally, I also think Sean made a really good point about follow-up, which is, burns and their evolution over time are going to be something that you have to invest in if you're going to take care of burns. So, a hand burn can become a real tragedy if it's not well cared for. And it could be something simple that will heal well. So it just needs a lot of observation and due diligence, exactly as you did, Mary, seeing them every couple of days, seeing them weekly. And then, as Sean was pointing out, see them annually and guide them through all of the scar management. The good news is that we have the opportunity to provide excellent outcomes for children. I think children have more access to that, perhaps because of the youthfulness of all of their tissues and compared to the senescence of an adult wound. So I really enjoyed the presentation, and I got into the burn business just out of necessity and have really enjoyed it. And I'd be happy to serve as a resource in telehealth also for our colleagues.
Yeah, well, I think Catherine hit on a lot of important points there. I think children are not little adults, and I think it behooves pediatric surgeons to be involved in, the critical care management. These are injured children, and no better people out there to take care of injured children than pediatric surgeons. So obviously I'm slightly biased, but and so I think we got to get to the point where we stop over treating kids. A 3-year-old is not a 30-year-old. And so we can, as we said, harvest their ability to heal. And our experience is that kids actually like to overheal. And it's the sequelae of the burn wounds that are often sometimes bigger problems than the actual burn wound itself. Going back to the 50% of the surgeons being trained, honestly, I think it's about recognition. It's the, Kenny Rogers, know when to hold them, know when to fold them, right? Know when to walk away. And you got to know when you can hold on to that patient and when that patient needs to get some really special expertise. And then the last comment that I'll make about telehealth is that we did that during COVID, and it's great, except when your patient lives 2 hours away and has limited internet access and you're having a real struggle seeing the image of the wound on, really bad internet. And then at that point, you might as well just be talking over the phone. So I'm happy to always act as a resource. You can call me just about any time. I'll answer the phone, and you can reach out to us, send pictures and things like that. But the telehealth's got a little ways to go. But great presentation. Really enjoyed being a part of it. Thank you.
Let me just follow that up with a quick question about telementoring. Have you all had experiences where you were helping a surgeon take care of their patient, and how does that process work?
You can do it. I mean, certainly, with most phones, like doing FaceTime. In fact, Friday, I was at one location and we were doing a wound check on a patient that I've been operating on. And just to have somebody hold it up and really look at the wound and kind of direct where you're going with it. I think that, FaceTime, not advertising, but anyways, some app like that works very well. And then you can just kind of walk people through. I think the biggest thing is just vigilance. Every day looking at that wound, and that's the most important part, I think.
And is that something that is a billable event or service?
I think it depends on your state. State of Florida had some pretty strict rules that they put in place, during COVID, that we could do telehealth, but the patient had to reside in the state of Florida. we probably get about 15 to 20% of our referrals from Southern Georgia. Their Medicaid doesn't pay. That doesn't bother me. It bothers the people who work 9 to 5 in the C-suite. But so, there are some issues like that. I honestly think that we just have to help the kids.
But we had some issues in New York just transporting kids, to a Shriners facility across, state lines that did come up also. So I do think we have to be, it's another source of motivation to get our trainees educated about just fundamentals of burn care and critical care, as Sean pointed out, knowing what resources you have, knowing what you can take care of in your home institution, and then, sending burns along when you've exceeded your capacity.
I got to tell you, in the military, we did it all the time. We did it all the time with deployed providers, or when I was in Hawaii, we did it with providers that were in the Pacific Ocean. And it was actually a very efficient way to deliver subspecialty care. But, we didn't have to worry about reimbursement and, to some extent, medical legal issues, but it really was a very efficient way to deliver healthcare. It was really good.
Great conversation. So we're coming up on the end of our time, but I really do want to spend the last period talking a little bit about virtual conferencing. All of you probably have heard that AAP announced today that they are changing. They're making a huge pivot, and they're changing their in-person conference to virtual conferencing. So we're going to be in this world for a while. So Rob, Casey, and Kathy, I'm really interested in your thoughts about going forward on what that's going to mean for APSA. One of the things that Dave talked a little bit about was that our technology maybe isn't perfect, and there are a lot of opportunities to do better. And then the other piece is that we miss out on the social aspect. So there can maybe be some other options that technology could help us with in terms of being able to create more opportunities to have one-to-one interaction, even in virtual world, such as, you know, some sort of avatars or being a second life type of scenario where you're in the virtual world. So I'm kind of curious what you guys think about that.
Yeah, I'd like to see Sean Larson do some karaoke with the Kenny Rogers he was just talking about. So I think we're missing out a little bit by staying a little too stuffy. Not this panel, of course, but as Casey mentioned in our discussion, just this interaction we're having right here, where we have 9 people on a screen and we're getting to interact with each other, is not something we would do in person. But we do need to pivot back to some in-person part of this. It has to be. We all have those memories of how important that was for us. So it has to happen for the younger trainees. And so I'm going to pivot us into San Diego if possible. But also, I agree, we have to hold on to some of what was gained by going virtual. And then Casey, you mentioned also it's money, right? This is going to be up to the cost.
Yeah, I can't even fathom how the AAP is dealing with it, because APSA, you know, traditionally for many years lost money on its in-person meetings. This is before COVID, and so there was there's essentially now a moratorium on our meetings being a cost sink rather than being cost neutral, which I think is a good thing. And the board, even the first year, I know struggled, and I know last year struggled with the decision to go entirely virtual. For a lot of reasons, but the practical thing is that APSA has to let the hotel or the conference center know by a certain deadline before they lose money, and then that's just money that's gone. So the deadline is important, and then there are all the other things like fear, balancing that with desire, cost, restrictions, the unknown, which is the real elephant in the room. And Eunice asked me before we started this whether or not if you hold a meeting that's hybrid, will that dissuade people from coming to the in-person meeting? And the answer to that is probably yes. On the other hand, it allows more people to gain the content. But on the other hand, when we're looking just from the Marjorie Arcus, treasury point of view, you certainly don't want to lose money on the meeting by not knowing how many people are actually going to attend in person. So there's a lot of moving parts and certainly some unknowns. But I agree with Kathy. I think many people would be willing to forego or willing to accept the risk of an in-person event like is currently going on in SAGES, to be able to meet up with people with mask restrictions, what have you, if it meant seeing each other in person.
Very cool. Well, thank you all so much for your time. This has been a great session. Thank you for taking the time to teach all of us something about your area of expertise. For all of our audience, you now have a couple of burn surgeons that you could call upon when you have patients that you have some questions about. And thank you for joining us tonight. And I hope you all have a safe and wonderful night.
Thanks, everybody.
Thank you.
Thank you.
Bye-bye.
Thanks.